Good. The topic we're talking about today is diagnosis of infectious disease, which I'm excited about because even since Edinger's been published, there's been so many advances in the diagnostic capabilities we have. And I think we're going to understand infectious disease, particularly with regards to how it impacts immune function. And, I mentioned we've been doing the immune-mediated disease subjects, but one of the things that Richard Malik said to me is that some people think that immune-mediated disease is undiagnosed infection. And as we see advances in diagnostic capacity, we're going to see improvements in understanding of those sorts of diseases as well. So there's a few different approaches we could take to this. Does anybody have anything specific that they want to cover?
It's a wide open field.
Wide open.
I presume we're going to limit ourselves to dogs and cats.
Dogs and cats, yeah, that's all I know.
Yes, please.
But
I've done postmortems on rabbits that could have, now just trying to think of the name of it, that spots through the liver, which could be a few things, but one of them is zoonosis.
Why are you doing postmortems on rabbits?
Why do I do postmortems on them?
Yeah, why as a medicine vet?
Because they're dead.
Yeah, I suppose that's a good reason.
I don't do it very often.
Yeah, so really what we're covering is just really like high level, how do diagnostic tests work, which population, how do they differ in their value according to the populations you apply them to, and what sort of diagnostic tests are available. So, and I think like very high level, it's are we detecting antibody or are we detecting organism?
Mm-hmm.
And most of the advances that we're seeing are detection of organism, particularly detection of genetic material from those organisms.
Yeah, the other point too, of course, before you even get to that stage, there's things like travel history and so forth, which
absolutely, yeah,
has to be considered.
And a knowledge of your local area. Like if you're locuming around Australia or something like that, and you don't actually know what infectious diseases are common in the area you are, it's important to be in a team that you can consult with other people and say, any idea what's going on here? Because it might be something they see all the time, like lepto, for example, in North Queensland, or Babesia, like different areas are going to have different endemic leishmaniasis in Europe. Lots of examples. So let's talk about, let's just start from a CBC, for example, and how that might, so history, we sort of know that we need to know about travel history and exposure to different things, like is there ticks in that area, is there tick-borne diseases in those ticks and stuff like that. But once we get to the point of like starting our investigation, let's talk about patterns we might see on our CBC that might help us identify parasitic, bacterial, viral disease. So can anyone think of a specific change that you see in a CBC that you're like, oh, interesting?
Eosinophila?
Yeah, I agree. That's the one I think we see most commonly. And what would it indicate to you?
I mean, parasitic disease jumps to.
Yes. Yeah. And interestingly, fungal as well can often cause an eosinophilia, particularly animals with disseminated fungal infections. What information might a lymphocytosis give you?
I don't know, I suppose I don't often think of it associated with infectious disease, but I might.
What would you differ if you saw a lymphocytosis? What would your differentials be?
I mean, how big are we talking?
8.
Okay, so not crazy.
Not crazy, no.
Yeah, I've forgotten Addison's, but I think it sends the lymphocytes up, doesn't it?
Yeah.
Oh, yeah.
But it's not infectious.
Mm-mm. But what else? Come on, you can do more than
Brains off a bit.
that. Good morning, wake up. Neoplasia is the other one, right?
Oh yeah. Well, yeah.
Yeah, but
So if we're talking about infectious disease, obviously. And when I say if you see a lymphocytosis on your CBC, it's not specific for a specific type of infection.
Mm-hmm.
And you kind of have to, if that's the only thing you've got to go off to further your investigation, you do have to rule out neoplasia, Addison's, and chronic antigenic stimulus.
Mm-hmm.
when you say neoplasia, Anna, you mean types other than the leukemia complexes and lymphoma?
No, I don't. I mean those types. Yeah,
Yeah,
that'd be by far and away the most common causes of lymphocytosis. So what I'm getting at is that lymphocytes don't go up with infectious disease until it's quite chronic. So sometimes you can get a bit of an indication based on like the pattern of neutrophil elevation versus lymphocyte versus monocyte, as far as like the chronicity of infection. So say you had a neutrophilia with a left shift and toxic change, it's going to be quite an acute infection with quite pathogenic bacteria or probably bacteria that's causing quite a profound inflammatory response. As opposed to if you had when the monocytes come up next, so you get pyogranulomatous sort of pattern. So those diseases like more chronic viral infections or more chronic bacterial infections will cause a pyogranulomatous response. And then the lymphocytes kind of come up last as far as that kind of pattern. So it helps you.
Fungal diseases cause pyogranulomatous response.
They can do, but they don't have that. They cause a local pyogranulomatous response typically.
Okay.
But when they're disseminated, much more likely to cause a eosinophilia.
Yeah, well, you will probably also see hyperglobulinemia in situations like that, would you?
They go together. Yeah, exactly. So once you've had antigen stimulus chronic enough to cause a lymphocytosis, typically that means that the lymphocytes are stimulated and therefore producing more antibodies, which are globulins, right? So they often go up at the same time. What about a basophilia? Does anybody ever see basophilia?
No.
Have you ever seen one?
No. So apparently it goes up with heartworm.
Oh,
interesting. Yeah.
Well, I don't see much of that, so
no, and like the normal range of basophils is like 0 on.
yeah.
Yeah. So we just don't really see them, and we work in such privileged areas that we're not seeing a lot of parasitic disease like that. What about a low platelet level with regards to what sort of infections might we see a low platelet level?
Makes me think of tick-borne.
Yeah. So in those diseases, often they've got a kind of element of chronicity because they've kind of got acute phases and then chronic phases, and often we don't see them right away. So you might see a low platelet and a high lymphocyte count in those patients. That might be the pattern there. What about in sepsis? Are they going to have a lymphocytosis?
Not usually.
Not usually.
Usually low.
Yeah, it's usually very acute.
Stress.
Yeah, exactly. It should be low normal, basically. But they might have a low platelet count, mightn't they? What about on biochem? What might you see with sepsis that might help you kind of say, okay, this patient's septic?
I'm wondering about hyperglobulinemia, but that not in acute sepsis.
Exactly. So that's going to take time to develop.
You might see a hypoalbuminemia though. I think that
might.
happens fairly acutely.
Yep, absolutely. Because albumin is one of our acute phase proteins, so that'll get consumed before it gets produced in excess.
And a hypoglycemia.
Yep, good, excellent.
I lifted the survival rate from parvo in a practice once by just telling them to check the blood sugar. The
Yeah.
survival rate improved by about 20%.
Wow, that's excellent. So parvo is one of the diseases that we can see quite profound changes with the white cells and platelets as well, isn't it?
Yeah, leukopenia, isn't it?
Yeah,
Mhm.
neutropenia often.
Yeah, blood platelets too.
Neutropenia, yeah.
What about bilirubin in sepsis? What does that tend to do?
Go up.
Go up. Yeah, exactly. So we know that often infections are causing a direct, like hepatic increase in bilirubin. Sometimes the infection can be biliary, and that's why we've got an increase in bilirubin. But with inflammatory cytokines, bilirubin goes up in sepsis. So you can have disease that's quite far from the biliary system or liver and still have, if it's systemic, still have hyperbilirubinemia. Particularly cats, they love getting high bilirubin, don't they?
Yeah, I agree.
Just a little bit high. Just makes you go, is it cholangitis or not? Good. So what about hypercalcemia? What infectious diseases might you see hypercalcemia in?
I would just see it in osteosarcoma,
Oh, infectious diseases.
infectious.
Yeah.
Well, osteomyelitis maybe.
Yeah, could do. You'd have to, the calcium homeostasis mechanisms are pretty good at balancing that out. So I would be very surprised to see it outside the reference range. But in theory, there's definitely going to be alterations to calcium homeostasis. If you think of your, oh my gosh, what is that? The letter, what is the name of when you do like an abbreviation of letters? And it's supposed to, when hypercalcemia, there's a like Addison's,
Oh, like damn it.
hard groins or something.
What hard ions? Isn't it hard ions or
Something
something?
like that. Yeah.
Oh,
Except there's a G in there.
The G in there.
Yeah.
That's the infectious disease, is
That's
it?
the
G.
one. Yeah. It's granulomatous diseases.
Oh yeah, of course. Okay.
Yes. Yeah. So particularly fungal. But in theory, things like mycobacterial infections and stuff might cause. We don't see,
I've never seen.
not in Australia. So it's
Okay.
often with the fungal diseases in the US.
Yeah, okay.
But yeah, not in Australia. Okay, so that's the kind of like, testing that we do all the time, little indications we might get. I don't want to spend too much time on that. It's sucking eggs a little bit. Let's get to more specific tests, and with a kind of in the back of our mind, are we testing for the organism or are we testing for an antibody to that organism? So cytology, what are we testing for?
The organism.
The organism, exactly. Yeah. So somebody define sensitivity for me.
Low numbers of false negatives. The way I remember it, it took me ages, but the way I remember it is sensitivity means no false negatives.
Oh, right.
Specificity means no false positives.
Good. Yeah, I like that. Okay, so how sensitive is cytology or
Poorly sensitive.
poorly sensitive? It's hard to find these organisms and to identify them definitively just looking down a microscope. There's not very many that we can see, particularly in-house with a diff quick stain and no special stains. Yeah. Like crypto might be one that you kind of like, boom. Yeah.
There might be some intracellular blood parasites.
Yes, good. Yeah, for sure. But very like you definitely can't rule out like a Haemophilus infection if you don't see it on a blood smear, right? And same thing with like heartworm, for example, like microfilaria on a slide. You might get really lucky and see one, and that's very specific, but it's not very sensitive. Like you might miss it, and there's going to be a lot of false negatives on there.
We know how to distinguish dipetyl anemia.
What? Sorry,
You know how to distinguish microfilaria from dipetalonema?
I've never heard of type 1 anemia.
It's the one that kind of looks like it, but isn't pathogenic, right, Jeff?
That's right.
Like worms in the blood. That's
Yes.
not pathogenic.
Yeah. But it's just, yeah.
Does that happen in humans?
Pardon?
Does
Oh,
that
God, I
happen
don't
in
know.
humans?
I don't really remember it all, but I think microfilaria have a bit of a hooked tail.
Oh my God.
I'd have to look it up again. It's so long since since the new heartworm preventions and so forth have come in, we just don't see it in Sydney anymore.
No.
Picked up about half a dozen heartworm cases in Riverston in 2009,
Yeah.
but after that, I haven't really seen any.
Yeah. I kept thinking with more people getting rescue dogs that we'd see a little bit of like we'd actually be exposed to heartworm infection more in general practice, but no. Okay, what about what sort of organisms can special stains help us identify if we're still doing cytology? How might you improve the sensitivity of that?
Well, they do special stains for mycobacteria, like the acid fast
Right.
stains.
Completely invisible with the kind of Diffquick and Gram stains, but with a specific stain. Do you know what it's called?
I don't know. They just come back and they say they're acid fast positive. I don't know. I don't know what it's called. It's not the Zeal.
Yes, it is. Yeah, it is.
Oh, Zeal Nielsen or something.
Yeah. Zeal-Nielsen stain. Yeah.
Okay.
And what about fungal organisms?
I mean, they often do pass staining. What?
Yes.
I don't know what that stands for.
Very good. Periodic acid shift stain.
Okay.
Yeah. I don't know how it works or why, but it highlights the fungal wall.
Mhm.
Most fungal organisms will highlight on a normal Diffquick or
Yes.
stain.
Yeah. Yeah.
But just there's some that you can sort of say definitively fungal with a PAS stain.
Mhm.
So that can improve your sensitivity of your cytology, but still not very good, is it? You still might be looking at a sample with no organisms in it, and it's going to limit your diagnostic capacity.
Is a dark field examination of urine for lepto?
Yeah, good. Yeah, awesome. And I think it's important. So I sort of said focus on a we detecting organism or antibody, but let's also think about the sample that we're submitting and how we can maximize our sensitivity by submitting a sample, for example, that's very appropriate. So like maybe if you're submitting a tissue biopsy as opposed to an FNA for cytology. Well, it's not cytology anymore, but it sort of is. Looking at the cells to maximize your diagnostic yield. So that probably applies more to culture, which I want to talk about next. Are we detecting organism or antibody?
Organism.
Organism, good. Yeah, excellent. And what are the limitations of culture?
So many. It's so
So
frustrating.
many, isn't it?
So frustrating.
Yeah.
There's aerobic versus anaerobic.
Yeah, exactly.
And what's the facultative anaerobes?
Mm-hmm.
Then, I mean, with gut studies, they say that the number of organisms from the gut, the microbiome that we can culture is only 1 or 2% or some figure like that.
Yeah, yeah. So there's this paradigm that they used to talk about is that only 1% of organisms are culturable, so that will actually grow in a lab. And now that they're doing molecular diagnostics, they've realized actually we're pretty good at culturing. We're actually culturing a lot more than 1%. Now that they're actually doing whole genome, like what organisms are here and which ones are we growing. The trouble is that the ones that grow are selective. So you might have 5 organisms in a sample causing, like in a sample, full stop, like fecal sample, for example, and you might grow 3 that are not causing any pathology, and the 2 that you can't grow because the 3 that grow easily out, like use up all the nutrients for the other 2, are actually the pathologic ones or pathogenic ones. So lots of limitations to culture, but gosh, it's satisfying when you actually get it, isn't it? Do you guys do many blood cultures?
I've done one
One
since,
ever.
well,
Really?
yeah, since being a resident, and it wasn't like we got nothing.
Yeah.
We did them in America a bit, but they said to be any good, you've got to do 3,
Mm.
separated by, I've forgotten, a day or a few hours.
A few hours, I feel like, and from different sites, and
And when they spike a temperature.
Mm.
yeah, right, okay, yep.
So they do blood cultures all the time on all humans. Like it's a really, really, really common test. It's low yield, but detecting bacteremia is really important because it's high stakes.
Mm-hmm.
And more now that we're kind of limited with what antibiotics we'll use empirically in patients that aren't very acutely unwell and don't need antibiotics right now for life-saving reasons, I think we're probably going to end up doing blood culture more and more often. And then the other reason that I think we should be doing more blood cultures, the endocarditis is massively underreported and it's very hard to diagnose. And it's kind of an easy test if we sort of manage the client's expectation. If you can do a blood culture like once a week for 3 weeks in a dog that has like a new murmur and is just a bit lethargic kind of thing, like I think those dogs potentially, if the echo is kind of inconclusive, it's potentially worth screening for. There's a lot of dogs that I do an echo on and I'm like, mitral valve disease. I'm like, that vegetative lesion on the mitral valve could easily be endocarditis.
Okay, so even in things that aren't really sick, I suppose I've only ever thought of it for things that are like
Yeah,
pretty sick, like, you know, pyrexia of unknown origin, like real sick type.
absolutely. Yeah. So
Yeah, okay, interesting.
the organisms that live on heart valves are very uncommonly very pathogenic. So
Okay.
like dogs that get fully sick, the septic dogs, typically have a gram-negative infection.
Mhm.
Whereas like if you think about the dogs with disco, they're sore, they're not sick often, or they might
Yeah.
not necessarily have a fever because it's gram positive and the cell wall's not as like pyrogenic, or you don't get that same kind of systemic
Mhm.
sort of signs,
Mhm.
borderline neutrophilia rather than a raging neutrophilia.
Mhm.
The similar organisms like the heart valves as like the discs,
Yeah.
so often gram positives, often just come from skin, Bartonella and things like that, just don't really cause too much of a reaction
Okay.
and very chronic kind of signs. So there was a study over 10 years ago now where they just did postmortem on dogs that died from all causes, and 4% of them had endocarditis.
Hmm.
Yeah, so massively underdiagnosed. But then if they're not fully sick with it, do you need to treat it? Is the other. I mean, these dogs didn't die of their endocarditis.
Yeah, okay. Yeah,
Uh,
right. In these cases, you do blood cultures like weeks apart.
yeah, potentially.
Yeah, okay.
Yeah. Just we're going to check, we're going to do a few repeat blood tests and make sure there's no increase in inflammatory markers, CRP is staying stable, and there's no bacteria in the blood.
Yeah, right. Okay.
Mm.
Yeah. I mean, you said it's low yield. Like, do you ever get a positive blood culture?
I don't do this.
No, okay.
Just say you
Checking.
should.
Mhm.
I'm not actually seeing, like, I recommend things, but I'm not actually seeing clients. So,
Yeah, no, that's okay.
many experts. So I don't know if they do them or not.
Just wondered. Yeah, okay.
But it is, I find it interesting that they consider it worth doing in humans a lot.
Mhm.
Um, so with urine or blood, like if you're submitting a fluid or effusions even, I've got an idea in my head, and I'm not sure if it's correct, but I think the bigger the volume that you submit, the more likely there is to be an organism in it.
Surely.
Doesn't that make sense to you? Yeah. So often we get these little like 3 ml syringes for cysto to submit for urine culture. I'm like, and particularly for pyelonephritis, I'm like, we know that there's less organisms in there. I want to submit 20 mils.
I wonder what they do with it at the lab. Like, do they just plate up Like I
Mm.
wonder, do they centrifuge it first? Do they just plate up 1 mil of the 20 mils that you sent? Like what? I wonder what they do.
So most cultures now are done in bottles rather than plates.
Okay.
Yeah. Because most of the like once they grow an organism, the bottle like changes color. So they're all put in like a reader, and it varies from lab to lab, but they'll be in a culture bottle, so simple culture bottle, and they just slot them into this thing, and then the color changes if it's a positive growth, and they detect the color change by shining a light through it, and they say this one's positive, and then they run all of the post like identification checks, like, okay, what kind of organism is it and what's the sensitivity pattern? I had this picture in my head of every single urine sample that goes in is like spun down, looked at under the microscope, plated with all of the like different like antibiotic sensitivity discs and stuff. It's not how they do it anymore. It's much more automated. Yeah, so and the other thing about submitting large volumes and submitting in culture bottles is you can submit for anaerobic culture as well, which is nice. Anaerobic culture bottles you can use. Oh, my dogs are being
Don't know what that is. Okay.
Yeah, we in America we always did both.
Anaerobic and aerobic. Yeah.
Yeah.
Oh, that's nice.
For urine as well?
Yeah. Yeah. I mean, chances of there being an anaerobic organism in urine is fairly slim, although I have had an emphysematous cystitis
Oh yeah.
found recently.
Yeah. Yeah, right.
And that one's like, it's going to be Clostridia.
Yeah.
Yeah.
I had trouble growing a bug in urine. Well, I'm just in the middle of it, but they saw a gram-positive bacilli, which I think might be Corynebacterium ureolyticum, but they can't grow it. And so I'm trying to talk to the microbiologist to be like, what can I give you so that you can grow this? I want you to grow it for me.
Yeah.
Yeah, so maybe I wonder if putting it not an anaerobic culture bottle, but just in something else, or maybe I need more urine, or I don't know.
Because they're facultative anaerobes, aren't they? Corynebacteria.
I don't know. I have to look it up.
Yeah. And they've got a very specific shape. They're like gull-winged. So often they can call it on cytology.
Yeah, okay, well maybe I need to ask them. Well, but I mean, then when you read about it, they're all so resistant that you really want them to culture it so they can tell you what.
Yes, exactly what you can use. Yeah.
Yeah.
Yeah, for sure. So that's a good segue into like now sensitivity testing. It's not a lot of the time it's not done with discs on plates. That just takes too long. And now with the kind of molecular genetic sequencing we can do, they can actually detect resistance genes and predict the resistance of organisms based on their genetic sequences.
Are they doing that in animal labs? I was only at the lab last year and they were still using plates with dots.
Oh, were they actually?
Yes, like I went to Vetnostics here in Melbourne and
Really?
they were still using plates with dots and sniffing. The microbiologist was literally sniffing the bugs to try and work out what they were. Yes.
Wow.
They had a machine too. So
Yeah.
they also the machine was looking at I don't know what it was doing. There was a machine as well, but
Yeah.
there were still plates with dots and they're still looking at it, measuring with a ruler. They're still doing all of that. So
Wow. Good.
no.
So
Is that good? I don't know.
well, the sequencing for resistance isn't perfect. And
Oh.
still, so you might detect a gene for resistance development. That might not be a gene that's actively being transcribed. So they can have the propensity to develop resistance in response to a blah antibiotic, but they might not actually have resistance to that. Like if you can kill it with that bug, then it's not a problem.
Yeah,
It does tell you have to be really responsible with your antibiotic choice, like because they will develop resistance if they're exposed to this kind of thing.
Yeah, okay, which is kind of useful information to have.
Really, yeah, it's interesting the stuff that's emerging out of that, but it's not as predictive as the discs.
Okay.
There is another way that they detect it called matrix assisted laser desorption ionization time of flight mass spectroscopy.
Okay.
I don't really understand what it does, but that's the name of the like automated method of sensitivity testing that's not actually molecular, but still, yeah.
Mhm.
And oh, sorry, that's like telling you what organism it is without doing all of the different like testing whether it likes to be grown at 42 degrees or 38 degrees and like all of that stuff. Okay, let's talk about ELISA testing. Does anyone know what ELISA stands for?
Enzyme linked something.
Go on, you keep going, Simone.
No, I don't know.
Immunosorbent assay?
Immunosorbent.
Yeah.
Yeah.
It is a big word, yeah. Does anyone know if ELISA tests detect antibody or organism?
Antibody.
Can actually be either.
No.
I know, a bit annoying. So
It's a sandwich. I just remember that it's a sandwich. ELISA test.
The sandwich.
A sandwich. Yeah.
So tell me, how does it work?
There's something on the test,
Mm-hmm.
and then what you're looking for binds to that, and then a marker is attached to it. That's the sandwich, and that the marker is what you see. Like that's what draws the line, or
Yeah,
it's a terrible description, but something like that.
So what's on the test is an antibody. That's what makes it an immunoassay.
Right.
So they've got little antibodies that are specific for whatever you're testing for. You might be testing for an antibody to like heartworm, for example. Yeah, a heartworm antibody. And so you've got an antibody that's directed towards an antibody. And so if that antibody scrolls across and our test antibody binds to it, the marker shows up. But you might equally be looking for antigen. So you might be looking for a Giardia organism, and that might bind to the antibody and light up the marker. So it doesn't fit quite into the organism or antibody, but it is good to have in the back of your mind. When you're like doing so most of our point of care assays are ELISA assays, and it's good to have in the back of your mind. In this test, am I looking for antibody or organism?
Yeah, it's like the FIV, FELV one.
Yeah.
The FIV is for antibodies, FELV is for organism. I think that's right.
In the same test.
Yeah. On the same little tiny thing.
On the same thing. It's so amazing. And the reason why that's important is because early in the course of infection, heaps of antigen, not much antibody. Late in the course of infection, not much antigen, heaps of antibody. So the sensitivity of each of those tests is going to depend on how early in the infection you're testing, and also how prolific organisms are in that infection. So some infections only like exfoliate, like if we look at trichomoniasis, it wants to exfoliate from colonic enterocytes every 3 days. So our sensitivity with that test is pretty low. Yeah. As opposed to E. coli in the feces, very high sensitivity. Okay. So what about if we're testing for toxoplasmosis? What tests do we have available?
Antibody tests?
Yeah, predominantly. Is there a way, say you were suspicious of toxoplasmosis centrally, what testing?
I do PCR, or you can do PCR on CSF.
Yeah, so you can actually test organism and antibody. So say you had a patient present with a 2-day history of pyrexia, hepatitis, pneumonitis, pancreatitis, and suspected encephalitis or meningoencephalitis.
And it's been on a meat diet.
And it's on a meat diet, exactly right. Very suspicious. It's a cat. Would you want to submit an antibody test or an organism detection?
Organism.
Yeah, good.
It'd be too soon for antibodies.
Yeah, I think so too. Yeah. You might get lucky and catch an IgM. because they're produced earlier than the IgG are.
Yeah.
But the chances of IgG being elevated 2 days into an acute infection are very slim. So obviously CSF would be amazing, but this patient's got cerebral swelling and you're concerned about doing a CSF in it. It sounds like it's systemically got toxo everywhere. So you could actually push the lab and they won't have so I've done this is why I'm mentioning it. They won't have like normal ranges and they won't be able to sort of tell you like
it's not properly quality controlled, blah blah blah.
Yeah, exactly. But I know that if I detect an organism in that patient's blood, I know that that's inappropriate, and therefore I've got a very high index of suspicion based on a combination of clinical signs and test results that we have systemic toxoplasmosis.
Okay.
So you could potentially challenge the lab to run a PCR on blood. And when it comes back positive, they get really excited and call you rather than write up the report. So I can't actually document this, but this cat's got toxo or this dog's got neosporosis. So that's just if you really understand the test and what you're testing for and what you might be able to get a result from. So they could potentially run that PCR on like aspirates of a liver that were suspended in fluid. So sometimes you can challenge the lab to really help you get a diagnosis. So what's PCR?
Polymerase chain reaction.
What's that mean?
Multiplying the DNA so you can find it.
Yes.
See it.
Yeah, amplifying, basically. Yeah. What DNA are we looking for? Whatever we want, basically. Organisms, typically. So it means we need to know what we're looking for. So we have to know the sequence of DNA that we're looking for and know that that's unique for that organism. And we can do PCR panels where we test for a variety of different organisms, but we need to know what we're testing for. It's not a broad net that we're casting with PCR. As opposed to next gen sequencing. Has anyone heard of that?
I've heard of it.
Yeah. So basically it's just sequencing the genetic material in a sample.
Everything in it.
Yeah. Everything. Yeah. Which is a really nice evolution in us understanding, like, for example, microbiome in the gut. We know that it's more than just bacteria. It's definitely more than just the bacteria we can grow that contributes to gut health. So being able to sequence all of the other organisms in there, the viral organisms, the fungal organisms, all in the same, like you just get a sample and you understand what organisms are in there basically and in what balance. That also helps us to predict resistance patterns because they can flag those patterns that are recognized across multiple organisms to form resistance.
Are our labs doing that?
Nah. The example that we've got access to is the dysbiosis.
Yeah. Which apparently it's not that hard to send. I've never done it, but apparently it's not that hard to send samples over to get it done.
Yeah, it's not at all. I just haven't done it. But again, talking to clients.
Last time I sent a muscle biopsy to the US, postage was $750. So I'm not sure that.
Did it make it?
Yes, one made it on time. One was exceptionally delayed, so the kind of fresh/frozen samples were no good.
Yeah, that's the devastating part, I think, of sending them to the US when they don't make it. I've done PTH when PTH wasn't available. Sent like 3 samples with like $750 each time. So annoying. And it has to be the specific temperature when it gets there, otherwise they won't even run it. Very tricky.
Mm.
So they're all the kind of series of tests that I wanted to cover, but I thought we could do a few like different cases. So let's talk about a 2-year-old cat with chronic progressive nasal discharge over 2 months. And this cat has an LCAT, which stands for
Latex Cryptococcus antigen test. Cryptococcal.
great. Excellent. So the test was positive. Can we believe this result? How reliable is this result likely to be?
Well, you back it up with CT, I think.
Oh, that'd be nice.
Look for a granuloma.
Yeah. Client says no.
I thought that this test was fairly specific.
So
I think I would believe it. I think I would believe it.
Yeah.
Yeah. In a cat that has nasal discharge, if there's a positive LCAT, I'd just roll with that.
Yeah.
Yeah.
In cats are the only species that you assess the progress of treatment with your LCAT.
Yeah.
When the LCAT goes to 0 or nearby, you can stop treatment.
Yeah. You want it at 0 for sure. If you've still got any LCAT in there, so that's essentially you're detecting organism in this test. So if you've still got any organism present, you want to still be on antifungals. So this is a test that's renowned for having very good sensitivity and specificity. Actually, it's very specific. Like you're not going to get a positive unless there's like a test stuff up, really, or unless this cat's not actually infected with crypto. It's just happened to have a crypto up its nose at the time, which would be bad luck, really, wouldn't it? Like the chances of that happening are very slim.
But I mean, if it's a blood test, right? So if it just happened to have a random crypto up there, then
it shouldn't be in the bloodstream.
Correct. Yeah.
Yes.
So like there needs to be like an actual infection. It needs to be
Yeah.
invading the tissues or whatever.
It should be. Yeah, exactly. So we're applying this to a cat that we're already suspicious of disease. Like we've chosen this test because we think there's a high likelihood that we either need to rule in or rule out crypto infection in this cat. What about if you cast a wide net, like you do with a PCR, for example, or like a diarrhea panel or something like that, and you're just doing a health check and you decide to add an LCAT onto a screen in a healthy cat. If that comes back positive, what are you going to do about it?
Don't run tests that you can't interpret.
Yes. Yeah, exactly. So if we look at like the positive predictive value of a test, we need to apply it to the population that we're talking about. So say this test has 98% sensitivity, which is what I've been like, that's what I had in my head when I'm doing exams, like, oh, cat's 98% sensitivity. That's 98% sensitivity in cats that we're suspicious of that have crypto.
Yeah.
So in a healthy cat, the chances of you getting a false positive is 2%. So if you do enough of them, 2 out of your 100 cats are going to come back with a false positive. So it's a very sensitive test, but when it's applied to the wrong population, it's inappropriate. What about if, so I have actually had a cat with a false negative LCAT. So it had pyrothorax. I don't know why we run an LCAT. Now I'm saying don't run LCATs in cats that you're not suspicious of disease. F5A positive cat with a pyrothorax, and we ran an LCAT, and it came back negative. And then on the cytology of the chest fluid, it was full of crypto.
Oh, wow. That's cool.
It is cool, but why was it negative? All tests have false negatives.
Sure.
It was cool, yeah. Okay, So, any questions about that? Nope. Okay, what about we've got a 5-year-old dog with chronic diarrhea. We run a fecal PCR and it comes back positive for Giardia. What are we detecting? Organism or antigen? Antibody, sorry.
Organism.
Organism, good. Yeah, genetic material has to be testing for organism. Excellent. Is the presence of Giardia in feces diagnostic for the cause of diarrhea? No. Interestingly, 40% of dogs without diarrhea will test positive for Giardia. 25% of dogs with diarrhea will test positive for Giardia. So it's actually, I would say that's like a negative predictive indicator. So, and I'm sure
You should be giving the dogs with chronic diarrhea Giardia.
yes, maybe it's part of like the microbiome, like it's almost like a probiotic. So yeah, another example of if you have a test that comes back positive doesn't necessarily mean it's the cause of disease. So we tend to love being able to say to clients, this is a infection.
We found something.
Found something, exactly. It's positive for Clostridium.
Got something to treat.
Yeah. But we really need to understand, particularly as these PCR panels do cast a wide net, we're going to get positives that aren't necessarily associated with disease. And I think the labs do good spiels usually at the end saying that, like, not necessarily associated with disease, but I'm not sure how many people read them. And you get anchored on that thing. You're like, oh, it's positive for Giardium. Well,
At least giving it some fenbendazole is like probably a reasonable thing to do. And
yeah.
they come back with, positive Clostridium or whatever, and people are throwing weeks and weeks of metronidazole at them, and then they come to you. And
Yeah.
Thanks.
Oh. Can't fix this one.
That's interesting, usually, but people still do that. But one of the webinars on gut diseases I went to recently, they said there is no reason to use antibiotics in any diarrhea. And I had one in just of course one case proves nothing, but in Gladesville that had been fed on metronidazole every time the diarrhea occurred. And so I then put it on Peptacell, which has a degree of antiseptic, and cured it.
Oh, interesting.
Well, as far as I know, I mean, I didn't get to follow it up, unfortunately.
Yeah. I was speaking to a vet who has an interesting approach in that she says to clients, I'm not giving you antibiotics now, but I am approving a script if you need it in 2 days' time. So she gives them what's the paste?
Procolon.
Yeah. And diet and stuff, and then says come back in 2 days. And she's like, every single one of them comes back and gets their metronidazole. I'm like, no, they don't.
Is that for acute? That's for acute diarrhea, is it?
Diarrhea. Yeah.
Yeah. Okay. I would tell them that they have to wait longer than 2 days. I'd be like, you've got diarrhea in.
I'm not getting metronidazole. But it is, I mean, like I go into so many clinics and metronidazole works is the attitude. Like
I think it's changing, but so slowly. So slowly.
I know, and what people say, they initially say, oh yeah, no, they got metronidazole or someone else prescribed it. Like people are scared to own up to using metronidazole. They know that they shouldn't. And that's what they say to me. And then when I make them feel comfortable, they're like, no, it was me.
Yeah.
These fecal PCR panels in particular, like I just like never do them. But with so many dogs, mostly dogs. I do them in cats occasionally actually to look for tritrachomonas, but in dogs I like basically never do them because I just don't know how to interpret them. Yeah. So but I feel like a lot of people in general practice are doing it because like it's so easy. You just get the client to drop a fecal sample, like send it off, and then like maybe you have a result. But I don't know. I feel like I'd only be recommending it in like some, where there's multiple dogs in a household affected, or I don't know, you've got some other
zoonotic or
inkling of like some actual contagious type.
yeah.
I don't know.
So my like I actually do recommend them quite commonly because it just helps us with the like big picture, and in particular for zoonotic diseases. So, Salmonella Campylobacter, and the other thing I use it as ammunition to convince people to stop feeding. Yeah.
Yeah, okay. Fair enough. Yeah, okay, fair enough.
Yeah. Oh,
Yeah,
look, this is dangerous for you. You should stop that.
yeah. Yeah, okay.
Well,
That's a good shout.
when I was at Tufts, which is in the 1980s, the latter half,
Mhm.
they introduced an antibiotic control, and we were not allowed to use them unless we put it through a committee.
Mm.
We had to have evidence, like there had to be a blood smear or an FNA that was indicative of the fact we needed it.
Yeah. That was very progressive.
Mm.
And I with metronidazole in diarrheas, I would think you need to do a fecal smear at least and look for Clostridium
Yeah.
there, but also a fecal float because smears aren't very sensitive.
Mhm.
But you know, just to, I mean, worms are very rare these days,
Mm.
and one fecal float won't pick up wetworm anyway.
Yeah.
But you know, I still think you've got to do that. I mean, coccidia would be something you would pick up on a fecal float.
Yeah. I find that like this, I feel like we're in a like point where there's going to be a bit of a crisis in terms of like vets feel really judged for using antibiotics, obviously because they're lying to me about their prescribing behavior. um, and there's a really strong, like vets are very kind people and they would never deliberately risk public health. But I feel like
But we're also people pleasing, and we want to make the animals better so the clients like us.
all of these things, but it's like, for example, we've got antibiotic prescribing guidelines for UTIs. We've got consensus statement after consensus statement that tells us when we should use antibiotics, which antibiotics we should use and why, and that we should always do a culture if it's recurrent. So, and then we're in a position where we're facing a client and they say, no, not paying for it. The antibiotics worked last time. I want the antibiotics again. If the risk to that patient is fairly minimal, the risk is to public health, not necessarily dog health, it's public health. Whose responsibility is it to pay for that? Is it the business owners? Is it the government? Or is it the pet owner? Because I don't think it's the pet owner.
That makes sense.
Yeah. So I think it's the government. Like
Yeah.
if it's a public health issue, then they should be funding
Interesting perspective.
the recommended culture that is for the purpose of public health.
I mean, the other thing I point out to owners, we use the antibiotics and the dog gets better. But if we didn't use them, it might get better anyway. And they frequently do.
Yeah. 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 Oh, absolutely. I do think we overuse antibiotics, but I think if we're trying to put guidelines in place in the face of a lot of our vets working in areas where people just can't afford the $200.
And culture is expensive. It's like, I don't know, $280 to the client every time or something for a urine culture. Like if I'm doing that, you know, if these dogs with recurrent UTIs, like we're doing it all the time.
Yeah.
Like
And the sedation for cysto and like, if it's not a dog that's amenable to a cysto conscious and stuff, like it's really.
I think though Melbourne Uni or someone, I think it was based out of Melbourne Uni. Anyway, they did some paper where they offered a bunch of, I think, Green Cross clinics free cultures for a period of time, free urine cultures.
Yeah.
Weirdly, like the number of urine cultures they did in most of the clinics have barely changed. It was, I forget who did the paper, but I just found it super interesting because if someone was offering me free urine cultures, I'd be like, right, every animal gets a urine culture. Like, how interesting. That'd be so cool.
You'd see in a complex case, don't test for things. The animal might be coming back time after time after time and adding consultation fees and inconvenience to the owner, where a rapid diagnosis the first time could well save all that.
Yeah. And it's a good justification but I think that in particular for things like skin disease and like I don't know, I can't think of any examples, but like a UTI, I just like we've got guidelines that say it's very reasonable to give it like first case pyuria, give them a course of antibiotics without doing a culture, and then the next culture is very hard to get across the line because they've had such a successful outcome. Anyway, if you can join my campaign in the government to pay for culture,
I'll start a petition.
start a petition with me. Yeah, I do because I don't know how else we're going to manipulate vet behavior. Like we can tell them that they have to eat culture till we're blue in the face, but unless they see that like that's necessary from a public health perspective, necessary enough that the government are paying for it, I don't think we're going to convince them.
Yeah.
I mean, how reliable are fecal cultures? I mean,
Fecal culture is a waste of time. Yeah.
If the salmonella was, which is a notifiable disease. I'm not sure about dogs, but I picked it up in pigs once and it was notifiable.
Not a lot of dogs are carriers actually of salmonella. So it's quite common they test positive, but it's not actually clinically significant unless they're like septic, in which case, yeah, significant.
The famous case of typhoid Mary, but apparently with salmonella, I read once that if you use antibiotics, it just forces the organisms intracellularly, and doesn't. So it's better to not use antibiotics on salmonella unless they're systemic.
Yeah, that's what I've heard. Unless they're septic, you don't need to treat it. I'm gonna have to run. I'm on school run this morning.
Can I just do a little plug in case? I mean, I know there's not many people here, but in case anyone's listening afterwards, that I am tasked with organising the Medicine Residents Forum for this year. It's in Melbourne on October the 25th and 26th. Please come because we don't have enough people coming. If you're an Australian college member, you can get funding for travel and accommodation. If you're not, you should come anyway and just have a weekend in Melbourne because it'll be fun. And email me.
How have I not heard about this?
I don't know, Anna, because the college said they sent an email to every specialist in the country asking for volunteers to speak. I'm not asking specialists to come to Melbourne to speak, but if anyone is in Melbourne or wants to come to Melbourne, then you'd be more than welcome. So please get in touch.
So that's the weekend before my birthday, and I might be able to come down, and I'll be very happy to talk about whatever you want me to talk about.
Are you serious?
Yeah, definitely. I'll email you.
Okay, email me. Thank you.
What are the
Public
dates
service
again?
announcement.
Yes.
The dates again?
25th and 26th of October.
Is there a theme?
Small animal medicine. No, there is no specific theme.
All right, good. Okay.
Okay, keep me posted. Yep.
Yeah, thanks, man.
Thanks heaps.
All right, see ya.
Bye.
Thank you. Great. Thanks very much again.